I'm very pleased today to introduce Dr. Nhial T. He's an assistant professor at the Brown with a secondary appointment at the WashU Public Health, which is us. And he serves as the associate director for research at the International Center for Child Health. His research centers on mental health impact of war trauma among youth from conflict-affected families resettled as refugees in the U.S. and those still residing in refugee camps in sub-Saharan Africa. And he develops culturally relevant interventions, community-based interventions to address mental health challenges. Dr. Tutlam is currently leading studies focused on addressing HIV risk and mental health among refugee youth in Uganda. Additionally, he is conducting a study to adapt and test a combination intervention to address emotional and behavioral health challenges related to intergenerational trauma. This is among adolescents born in the U.S. to parents who resettled as refugees. Before joining WashU, Dr. Tutlam received his MPH and PhD in public health from St. Louis University, and he also served as the lead chronic disease epidemiologist at the St. Louis County Department of Public Health. So a lot of experience there, overseeing chronic disease and mental health surveillance. And his responsibilities also included assisting and advising the department director and division directors on the formulation of evidence-based recommendations for interventions to reduce the occurrence of diseases of significance in public health. He's worked with multiple key partners, very collaborative in federal, state, and local health departments, academic and research institutions, community-based organizations, hospital systems, and I'm going to guess a few people in this room. So with that, it's been a pleasure to talk with you this morning, and I'm looking forward to your talk as well.
Thank you so much, Natasha. Thank you so much, Professor Joshua, for the kind introduction. Really grateful to be here today. Something that I should mention right off the bat is a long time ago, many years ago, Professor Joshua was on my comp committee. Some people here know what comp committee is from St. Louis University. And I was really nervous as an FE student that time trying to answer some of these behavioral health questions. And she said, don't be nervous. So she made me feel better that time. So hopefully I'm not as nervous as I was back then today. So really, I'm really excited. Welcome. It's so good to see so many familiar faces in the room here, as well as those of you following on Zoom. Welcome. So I'm really, really excited to talk about my work today, focused on addressing mental health issues among young people affected by conflict, whether they are here in the United States or whether they are in the refugee settlements in sub-Saharan Africa. So I often like to say that I have my feet on two different continents, hence the AI picture that you see there. So I do my work both in sub-Saharan Africa, in Uganda, in particular, and in the United States here as well. So today I'm just going to highlight some of the projects that I've been conducting here both here in the United States and in sub-Saharan Africa. Then I'll start with my project that I'm implementing in the United States here. This is a K01 project that's funded by the National Institute of Mental Health, focused on intergenerational transmission of trauma among children who are born here to parents who moved to the US as refugees. And then I'll also talk to you about my work here focused on HIV, young people living with HIV in the refugee settlements in Uganda. And then I have another project that is focused on understanding mental health outcomes among young people living in refugee settlements and among young people living in urban centers in Uganda. And hopefully I'll close with the project. This is something that I'm passionate about, capacity building, research capacity building for refugees that we just finished implementing last year. So I'm going to tell you a little bit about my journey, how I got to where I am today. So over the years, I've been really, really fortunate, very lucky to work with incredible leaders in our field. So I started as a research assistant in the Department of Medicine in infectious diseases, working with Vicki Fraser. Some of you know who she is. And then I transitioned on to become a research coordinator in the Department of Neurology, working with Ann Cross and Rob Naismith, doing some really cutting edge work around multiple sclerosis research. And in this work, I did everything from patient recruitment to to doing the MRIs myself, scanning the optic nerves of these individuals. I remember we used to have a coil that some guy in Germany made for us to be able to see the optic nerves using this custom-made coil, doing the assessments, processing the data, all the way to data analysis. So I really did all of that work. And then because I had questions that I was interested in personally, which I'm pursuing now, I went back to St. Louis University to pursue my PhD to be able to answer some of these questions that I was personally interested in. And then I came back to WashU. I have a friend at the medical school who says you'll never leave WashU. I came back to WashU to work as a data analyst in the Department of OBGYN. One of our colleagues, dragged me here, was actually my mentor there at that time. And then I took up a position in St. Louis County Department of Public Health to go lead a newly established chronic disease epidemiology program that they were just starting. Part of my responsibilities was also to start up the mental health surveillance program. We were having a lot of discussions around mental health at the time. And then part of my responsibilities also, and I don't know how I ended up there, I was handed this, actually I led this project. I was told you could lead the, from the development all the way to the implementation of it, looking at addressing youth violence in North St. Louis County. So we worked with 3 school districts, we worked with the police department, police athletic league, and this was a large federally funded project that I led at that time. And so for me, as a resident of St. Louis County, when I was at the health department, I had the opportunity to hire some people. And 2 of those people now are in senior leadership positions at the health department. One of them actually was a student of mine. He is an MP student who has now my old job. So I feel like we're in good hands in that regard. And then I decided to come back to academia as a postdoc, where I was mentored by Brett Salmalas, who is, and Mary McKay, our executive vice president. And then transitioned on to a faculty position in 2023. So here I am. So I tell you all of this to tell you that all of this experience at work is really what informs and guides my scholarship as a researcher, collaborating with other people doing this multidisciplinary work to develop and design and develop culturally congruent interventions to address mental health issues that are affecting people that have been affected by conflict, those both here in the United States and those still living in refugee settlements. And so people often ask me why I do the work that I do. Part of the reason I do is I'm a child of war. I grew up in Ethiopia, mostly originally from South Sudan. So in some of the trauma assessment questionnaires that we have, the Harvard Trauma Questionnaire, there are a lot of questions about the kind of trauma that you've experienced. So when I'm asking these participants, a lot of those traumatic events are like, oh yeah, I've been there, done that. So some of these that I ask my participants really I've experienced those personally. I've stayed in bunkers, hiding from government or planes. I've been in the bush, hiding from bullets and all of that. And I've lost my own loved ones in the war, as my dad died about 28 years ago now. So all of that motivates me to do the work I do. So this research that I do is not just an abstract exercise for me. It's based on personal experience that I So all of us in this room hopefully know that, and some of those of us on Zoom know that war really has a devastating impact on health outcomes of people. So as described by Levy and Seidel, there are indirect and direct consequences of war that happen. So in the brown circle that you see here, they talk about these indirect consequences. So what typically happens is those people in charge who want to hang on to power redirect resources to, instead of building hospitals or buying medicine, they buy bombs and tanks and all that to put down whoever they are fighting. And then you can also see destruction of infrastructure that happens in terms of, not so long ago, at the end of the last year, an MSF hospital was bombed by the government of South Sudan because they thought that it was treating opposition forces. And so you can see what this does in terms of people being able to access healthcare. And so if people can't access healthcare when they already don't have enough access, that becomes a problem. Then in this yellow box, in this yellow circle here, there are what they call this direct impact or direct effect of war on populations. Obviously, infectious diseases become rampant. Some of these most recent large cholera outbreaks that we've seen happen in some of these conflict areas. And so that typically happens. Poor nutrition becomes a problem. So in the refugee camps where we work, for example, food rations have been cut by as much as 70% now, and that has negative impact in terms of what people are able to, whether they are able to take their HIV medication or not, and things like that. And of course, mental health, which is the focus of my scholarship, also gets impacted. And as you can see from this, from the table on the right side there, is what we call trauma-associated mental disorders really are quite high in these war-affected folks. Derek Slope, an Australian psychiatrist, suggests that the mechanism by which these mental health issues come about is when these, what he calls psychological pillars are disrupted. So when these psychological pillars such as, safety, bonds, justice, existential meaning, all of these, when they are disrupted, and some of these are the ones that are disrupted usually in war, that's how the mental health of individuals is affected. So now with that background, I want to talk to you about the work that I've been doing here in the United States focused on intergenerational transmission of trauma among these youth belonging to refugee families that have been resettled in the United States. So from the literature, we know that young people, and these are young people belonging to these families that have come here as refugees in high-income countries, there's a of these trauma-associated disorders, PTSD, depression. You can see up to about 54% for PTSD, depression up to about 30%. These are young people in high-income countries or don't live in the refugee settlement. And so, and essentially, we've also been seeing some of this. I've been seeing this in the communities that I work with, primarily in the South Sudanese community, where people are dealing with a lot of issues, right? In cases of suicide, substance use, mostly overdose deaths that have been happening in the last 10 years, that the community doesn't want to talk about. People are very reluctant about to talk about what these kids are dying from. And obviously then there is youth violence that has become really, really a serious problem. For example, in places like Omar right now, some of the gangs are South Sudanese gangs, these young kids who are from South Sudanese communities. And my hypothesis is that some of these things are really related to the intergenerational transmission of trauma that is happening within the community. And this problem has gotten so bad that, we wanted to sound the alarm. So we published a paper with my colleague here, Salma Abdallah, last year in this Lancet publication to basically raise the awareness so that people can pay attention to some of these things that we're seeing in the community. When I talk about this work, I like to show this quote from this book by David Morris. David Morris is, for those of you who don't know, is a former Marine who went to the first Iraq war as a Marine and fought in that war, and then went and covered the next Iraq war as a journalist. And so as they were traveling in this Humvee with the unit that he was embedded in, the Humvee hit an IED, and miraculously, nobody in that Humvee died. But then, the consequence of that, he died with a severe case of PTSD afterwards, and that's what led him to write this book. And in that book, he says, despite the quixotic claim of modern neuroscience, there is no cure for trauma. Once it enters the body, it stays there forever, initiating a complex chemical chain of events that changes not only the physiology of the victims, but also the physiology of the offspring. And I've highlighted that because that's really the focus of what I am doing here. And what I think he's getting at here is this notion of intergenerational transmission of trauma, that trauma doesn't end with the individuals that have experienced it directly. And the famous psychiatrist, Better van der Kolk also writes this in his book, The Body Keeps the Score, talks about something similar as well. And so what is this concept of intergenerational transmission of trauma? So Kellerman defines intergenerational transmission of trauma as this process through which trauma that happened to one generation gets somehow passed on to the next generation. And there are actually other researchers who have gone actually further, going to the third generation and even fourth generation. So that doesn't stop with the second generation. And this conceptual framework that you see here is from my dissertation work, where I was trying to conceptualize how this trauma that mothers, primarily South Sudanese mothers who are resettled here, pass on that trauma. So first of all, we talk about these trauma-associated disorders, as you can see, anxiety, depression, and PTSD that happens as a result of experiencing this war trauma. But we also know from the literature that intergenerational transmission trauma is manifested in the children as all of these outcomes: aggressive behavior, antisocial behavior, anxiety, depression, and PTSD. And I wanted to be able to capture, and that in that model, I've also included risk and protective factors to see what makes it more likely or for individuals to go on to develop these mental disorders or not. And so from my dissertation work, I published this first paper looking at just the women. As you can see there, so almost about 40% of these mothers met criteria for what would be considered anxiety. And then about 29% of them met criteria for what we call current depression. About 26% of those met criteria for PTSD. So this is consistent with what we have seen in the literature so far. And one thing I also want to point out is that if you look at that bottom row right there, almost half of those participants reported that they experienced 11 or more traumatic events. And so the more people traumatic event experience, obviously, there is more chance for individuals to develop all of these mental disorders. And then I published a second paper looking at just these behavioral and emotional problems just among the children. As you can see there, depression is about 7% for these young people, 8% antisocial behavior, and PTSD is 11%. Now, there isn't an apples-to-apples comparison with the broader US population, but from the data or whatever I was able to find, you can see for young people, 3 to about 17 years, most of the participants in my study were about 5 years to about 17 years of age. You can see PTSD is about 3.5%. You can see that obviously there is something going on within this population as well. And then looking at whether this notion that intergenerational transmission of trauma does exist. So when we looked at the joint effect of trauma of these parents and anxiety, for example, you can see that increased the odds of these young people developing depression by about 36%, similar to trauma and depression, about 46% in trauma and PTSD by about 47%. So that is consistent with this notion that there's this idea of intergenerational transmission of trauma happening in this community. So a long time ago, I bought into this idea called consequential epidemiology, after reading one of Ross's books. And so then we didn't want to stop at figuring out it's one thing to just find out, okay, this is happening in the community. What do we then do about it? And so I wrote a K grant, which was fortunately funded. I received funding to be able to do that. This is our protocol paper about where you can find all of the details that in terms of what it is that we are doing with this particular research. At this point, I just want to say, I have the A list of mentors. Really, really blessed to have mentors: Fred Mala, Mary McKay, Byron Paul, Teresa Betancourt, and all of this. I really want to acknowledge my mentors for supporting me in this work. So this work is being implemented in Omaha, Nebraska. For some weird reason, Nebraska has the highest number of refugees per capita in the United States. If you ever figure it out, let me know, because I don't know how I've been asking people. So the participants, about 154 young people, youth 14 to 17 years of age, along with a biological parent in this part. So we'll end up having about 308 participants in the study. And so this is a randomized control trial. So we have the usual care. So we are assuming that these young people, whatever services they're getting, either in schools, in their communities, and that's what we're considering the usual care. And then we have a combination intervention consisting of what we call multiple family group. This is a family strengthening intervention that was developed by our own Executive Vice Provost, Mary McKay, in 1995. And so that intervention is expected to, strengthen family and social support, improve family functioning, reduce the stigma related to seeking mental health care, which is very important for this particular population. As you know, stigma can really be a challenging case. And then the other component of the intervention intervention, we are calling it virtual TAC or Teenage Health Consultants. This is an intervention I actually helped deliver when I was at St. Louis County Department of Public Health when we were trying to address minority youth violence in North St. Louis County. And so I thought this intervention would be appropriate for this population in terms of thinking aggressive behavior, antisocial behavior, these young people that we're dealing with in this population. And this actually what I've done is that I've adapted this to be delivered as a virtual intervention, learning lessons from COVID. So I was delivering this intervention in the middle of then COVID comes and then we had to shut down and we couldn't deliver that intervention. And so part of my motivation for adapting it was like, if we should ever have a pandemic, we would still be able to continue with this. And so this intervention is expected to improve peer support and improve pro-social attitude. And our hope is that this intervention will help improve these mental health outcomes that we are interested in, both for the parents and their children as well. So this is another representation of how I think conceptually how this intervention will be able to improve mental health outcomes in this population. So for example, if this multiple family group can improve peer support, and if peer support can help reduce the stigma here, and then that stigma, then reduction of stigma, then necessarily will go and improve mental health outcomes for individuals. There are the two theories guiding this intervention. So the social action theory and the family systems theory. As you can see, the social action theory posits that a person's contextual influences impacts their self-change processes and in turn impacts their actual health behaviors and action, which is what we want to happen. And then the family systems theory defines the family unit as this complex system in which members interact to basically influence each other's behavior. And so that's also one way we think of how these mental health impacts can be impacted. So in terms of where we are in implementation of this project is, so we're right now in the middle of delivering the intervention. The intervention, as I mentioned, consists of these multiple family groups and virtual teenagers consultants. In the multiple family groups, some of the topics we cover include building family, dealing with stress at home and environmental stressors, giving them problem-solving techniques and, addressing stress. And then in the virtual teenagers consultants, we are talking about things like every choice counts to teach these young people, every choice that you make counts and can have consequences for the future, positive outlook on life and coping with depression specifically and bullying. So when I was at the health department, when we were talking about interventions to deliver to these young people, bullying came up from the school districts as a big issue in these schools. And so I imagine this is also a big thing in this community as well. So I mentioned that I do my work in the global context in the real sense of the word. And so it's important to make those connections between what happens at the source and what happens here. And so a few years ago, I published this meta-analysis specifically looking at mental health outcomes for these populations, particularly South Sudanese who live so in three different contexts. South Sudanese still living in South Sudan, and those living in refugee camps, and those now living in high-income countries. And so as you can see there, for those living in South Sudan and those living in the refugee camps, the prevalence of PTSD in particular, somewhere around 40%. Slightly lower for those people living in high-income countries, but that's, I think, a function of not having enough studies that have been conducted in this population. So as you can see, there's only a couple of them that met criteria for this particular paper. So hopefully in the future, we'll revise that and see where things are. So now I'm going to shift gears a little bit and take us on a tour to Uganda to see where they just had election a couple of days ago, to talk about our project addressing mental health issues and among this population living with HIV. We work in Bidibidi, the largest refugee settlement on the continent. So you can see there, this as of the latest data from the end of last year, about 208,000 people. At the peak, it had about 270,000 people in this camp. We work in three settlements, so in Bepi here and Rhino camp, some of the largest camps. So a total population of about 487 right now in this area where we work. So for context, again, we work in BDBD. Uganda ranks #1 in terms of the number of refugees it hosts on the continent of Africa. There's roughly about 2 million refugees in that country. Most of the refugees, as is the case in most places, they are women and children. So youth between the ages of 15 and 24 constitute a large chunk of them. And as I mentioned earlier on, the biggest problems they have been dealing with over the last few years now is this reduction in food rations by up to about 70%. They've created these 3 categories of refugees. And so if you are in the 3rd category, you are able-bodied young man, of course, you don't have a country, but you're here, and the only thing we are going to give you is this security, figure the rest of your life out. And so that's what some of these people are dealing with. Now, so I've mentioned HIV there, and so we're focused on HIV. So in terms of the refugee population themselves, HIV prevalence is actually relatively low in the refugee population. But some of these refugees are now settled in some of the places with high prevalence of refugees, and even with increasing cases of HIV in some of these cases. And so really based on all of the risk factors that refugees have, we wanted to be able to focus on that population. So yeah, going back to that point again, as to why HIV, why we are focused on that, there is basically a very important intersection between mental health and HIV, as you can see. Because of war, this interaction between military and civilians sometimes, there's this increased risk of contracting or spreading HIV because some of these wars, rape and sexual violence is used as basically a weapon of war in some of these populations. Our colleague Kim Salinger does important work around this. And we also know that as a result of conflict, there's increased prevalence of these trauma-associated disorders. And then there is this that creates this vicious cycle that you see here in this diagram. Mental health, increases the likelihood that these individuals will engage in, risky behavior. And then if you have HIV, then, in turn, you could develop mental health. So this vicious cycle continues. So it's important to address this dual threat of public health threat in this population. We started working in the refugee settlements about somewhere around 2022, and we basically just went to the refugee camps and showed up and started working with some of these partners. And as we started talking with the partners, one of the things we started hearing was this idea. And at that time when we started this, actually food rations hadn't been cut that much. But they were hearing from these young people that, hey, I can't take my medication because I don't have enough food and all that. And quickly we realized that, in terms of viral suppression, even if you're giving these individuals their medicine, if they're not taking it because they don't have enough food to eat, then viral suppression that we are interested in really will not be there. So we started to get worried about that. So we sounded the alarm in this publication that we published in the Lancet to basically raise the awareness again to say, this is a problem we need to pay attention to that. We shared that with UNHCR. We shared this with the Ministry of Health in Uganda to just tell them this is something we are expecting. And so part of the reason why we focus on viral load suppression is that obviously, as you can see, it's one of the 95 targets developed by UNAIDS. And viral load suppression actually is also considered a prevention measure now because when your viral load is suppressed, you cannot transmit HIV through sex. And so that is an important way for us to prevent it. In fact, public health messaging now has switched to sort of, undetectable equals untransmissible or U equal U. So in that regard, it is very important for us to pay attention to it. So we designed this study, this 3-arm randomized, cluster randomized controlled trial. Basically, first thing we wanted to do was to adopt this intervention called the Youth Readiness Intervention, and then combine it with economic empowerment intervention, which consists of youth development accounts and financial literacy training that we wanted to do. And so in terms of, so this basically usual care, again, we expect the things that these refugee youth are receiving from within the refugee community centers would be that, and then the youth readiness intervention only, and then because we wanted to see if can youth readiness intervention only help these individuals, and then what does it look like if we combine youth readiness intervention with the financial economic empowerment intervention? Would it be different? So that's what we're trying to see here. So for those of you who don't know, the youth readiness intervention is a psychosocial intervention developed by one of my mentors, Teresa Betancourt, who, by the way, will be here next week. I'm really excited and looking forward to our talk. And so this youth readiness intervention was designed to address mental health issues among former child soldiers in Sierra Leone. So Teresa was working with former child soldiers in Sierra Leone who are being reintegrated into the society. These are kids who were trained to become killing machines in a sense. And so as they were reintegrating into the society, they were dealing with a lot of this trauma. And so this youth readiness intervention was designed to do that. And I thought, because even though this population has not gone through nearly the same amount of things that these young people went through, it's similar experience, and I thought this intervention would be helpful. And so it's designed to improve interpersonal community relationships, help them regulate their emotions, problem-solving skills, in terms of how they deal with stress. Belly breathing, for example, is one of those things that are part of this intervention. And then, of course, the youth development accounts plus the financial literacy training, the economic empowerment piece is supposed to help and to provide hopeful, these young people, give them hope for the future and all that. I'll show you why we stick. And I think that this then ultimately will help reduce, improve these primary outcomes that we're interested in, viral load suppression and improve mental health. And secondarily, we are thinking of improve sexual risk behavior taking, financial stability, and things like that. So this intervention is based on these two theories. That's a theory developed by Michael Sheridan at the Brown School, which posits that, when people have resources, have assets, that tends to improve their psychological well-being. And so that's what we're thinking with that. And obviously the youth readiness intervention, or YRI, is based on the cognitive behavioral health theory. So I mentioned earlier on, we started to get concerned about what we were hearing about viral load suppression in this population. So when we actually got our data, started looking at the data, that data now confirmed our worst fears. So a lot of our PhD students and so was part of this research. And so we found that viral load suppression among these young people was only 52%, which is obviously a far cry from the 95% goal that was set by UNAIDS. So that we think that's not good. We need to do something about it. So just some of the results I also want to highlight. So we asked people about whether they saved any money or not. And so those who reported actually were about 2.7 times as likely to be virally suppressed. So there is something there. And then we also, in terms of disclosure, those who had been disclosed to were also almost twice as likely to be virally suppressed. And this is important because some of these young people are taking medication without knowing necessarily what they were taking the medicine for because of disclosure rules. The parents, have the option to disclose to their children or not. And then those who reported that their treatment supporters. So we ask questions: who do you consider as your treatment supporter? Is it your family members, sister, a parent, or those who reported that there were teachers or there were healthcare providers were 5 times as likely to be virally suppressed, and that we think is important. So in terms of the key findings, so we think that financial literacy really appears to be a facilitator for reduction of viral load suppression in this financial empowerment, appears to be a facilitator for this. And then we also think that in terms of the viral load non-suppression, which is driven largely by this lack of food in the community, we think that international aid agencies can play a critical role in terms of addressing the pandemic through what we call food security. We published a second paper from this data looking at the social determinants of mental health in this population as well, because we wanted to look at that in this population. We wanted to look at some of these factors that were proposed by Compton and Shim in 2015. And so when we looked at that data, I know this is a busy slide, so I don't expect you to strain your eyes to look at that. I'll tell you what are some of the key highlights here. So we see that in terms of depression, you can see that female gender was associated with higher symptoms of depression. Oddly, school enrollment was associated with higher symptoms of depression. We tend to think of schools as protective. When we look at the results of your PTSD, that's flipped, and so that's important. And then obviously stigma, HIV stigma was associated with higher depressive symptoms as well. Then in terms of looking at hopelessness, and so those, so when we talk about employment status, those who were not employed, it's hard to find jobs to begin with, but there are people who can find jobs in some sort of employment. Those who are employed, who are not never employed, were actually about 2.4 times likely. Their hopelessness score was much higher compared to the rest. And then again, stigma is again was associated with a higher score of hopelessness. But for those who also, again, just curiously, this finding for those who reported that they lost their parents, and these parents, they could have lost them during the war and all that, had lower symptoms of depression, of hopelessness, lower score of hopelessness in this data. And then looking at PTSD, so those give the only thing I want to point out here. So the school enrollment seemed to help with fewer symptoms of PTSD in this population. And then those who reported that their health was good also had fewer symptoms of PTSD. Again, just to reiterate some of those findings, these important social determinants of health, such as school enrollment, having lost both parent, HIV-related stigma, were predictors of mental health outcomes among these young people in the population. In terms of where we are in this study implementation, so as I mentioned earlier on, so we basically collected baseline data. We delivered the intervention, the youth readiness intervention. We taught them financial literacy. We opened bank accounts for the people in the financial literacy component, those who receive financial literacy. And so then one of the things that we also did with that is we worked with the banks so that we can get bank statements every month. And so we see who saved. And so those who saved, the project matched their savings 2-to-1. So if somebody saved $5, the project gave them $10 at the end of the month. And we made sure that that was the case because we got the reports directly from the bank. And we work with these people, and this is their money. So the hope is that they can use this money to buy food, and therefore they would be able to take their medication at the end of the day. And we followed them up for about 6 months. And so that 6 months period elapsed, and then we went back and now did data collection. So we're literally in the middle of analyzing that data now to figure out if the intervention had any impact or not. So stay tuned, we'll be able to share that with you. Another project that I want to highlight is this project looking at comparing those refugee youth who live in the refugee camps. So there are, in the refugee in Uganda, there are refugees who live in the camps, and there are refugees who live in urban centers. Actually, Uganda, in terms of refugee policies, Uganda has some of the most progressive refugee policies in the world, which is sometimes it's hard to wrap your mind around, but that's the case. And so we recruited young people from Bidibidi, and we recruited young people from the town of Arua, which is an urban center, and we wanted to compare their mental health outcomes. So we've completed that data, and then we are analyzing right now to see what happened. And I'll be curious to find out, based on Professor Lindsay Stark's recent paper that came out, was it last week or came out last December, but the way she found that those living in outside of the camps tend to fare better. And so we'll see what happens. And so we're curious to find out. We'll let you know. Another project I really want to talk about is that I'm very passionate about is this capacity building. So we know that there are unique challenges in doing work in the refugee setting, humanitarian settings. Professor Lindsay knows this. It is exceedingly difficult to do this work in refugee camps. But we also know that there are these unique public health concerns that can only be addressed through doing research in these humanitarian settings. The NIH, before last year, probably agreed with us on that one, in the sense that they actually helped set up this global forum on humanitarian health research, along with other funders, to specifically help build capacity in this low and middle income countries to be able to address this. So we actually took advantage of some of those things that they were thinking about and wrote this proposal, say, hey, what if we recruit refugee youth and train them to become researchers? And fortunately, they gave us money to be able to do that, and we were able to do that. We implemented this project in 3 phases. So we first went and talked with stakeholders. We talked to people from UNHCR, IRC, people from the Office of the Prime Minister. The Office of the Prime Minister is responsible for refugee welfare in Uganda, so you have to go through them for any work that you do with the refugees. And the refugee community leaders and refugee youth, and we like, what is it that you would need? So we were anchoring this to be able to then develop a curriculum that is focused around intervention research. And so the researchers focus on intervention research, implementation of it, and of course, we can't run away from ethical conduct of research, and so we wanted that as an important component of that. We partnered with Uganda National Council for Science and Technology. That is the regulatory body, and so they actually came to partner with them. They are the ones who did the ethical conduct of research training for us. And so we were able to recruit 30 people. I will tell you, we weren't sure what to expect when we posted the advertisements calling the call for applications. In less than a week, we got over 400 applications for 30 slots from across Uganda, refugee camps in Uganda. And we were like, what do we do? So it was really difficult to pick 30 people. So we would like to think we took the best of the best. So I told my colleague, Proskovia, like we'll just decide, okay, we have enough women in the group, we have enough men in the group, there's enough representation from the refugee camps in the different camps, because there are camps all over Uganda, in the northern part of Uganda, the western part, the Rwandese, the Burundians and all that. We ended up actually recruiting a very good group of people. We had teachers, we had university students, so the requirement was they had to have some college level education to be able to understand the materials we were going to deliver to. And so we did that, and we brought them to iChat Training Center in Masaka for immersive learning for about 10 days, and we trained them. And one of the things that we wanted to do was to continue mentorship with these young people so that they can continue to ask us any questions in terms of doing research. So this is a group of them. We have some people in the room here who were part of this team, and really incredibly important training, and the people loved it. So now, coming towards the end, so I just want to show some of the studies that I'm engaged with. So these are research proposals that are either in development or proposals that submitted, were rejected, and we are retweaking to try to figure out how to do them. So one of them is actually being reviewed today. So send us all the good wishes, fingers crossed, toes crossed. Yeah, so there's a proposal to do work here in St. Louis with Dr. Juliet Wilmore and Dr. Daniel Mao at the Department of Psychiatry. So submitted an R21, R34 that wasn't really, the reviewers didn't like it. So this focused on addressing violence. I'm working now with Dr. Julia Frickman, one of our new colleagues here, to try to help me think through. She's given me feedback on this. That's been very helpful to try to figure out how do we retweak this to hopefully get a good score on that. I've worked with Massey Mutumba and Proskovia. We submitted an R34 last year that was just withdrawn without any explanation. So we are retweaking that to address that. And then McCoy on a project that worked on with Massey and Ryan Lindsay to address suicide in St. Louis here. I have not listed every project that has been rejected. There's a long list of them. We often talk about successes. We don't talk about our failures, but the failures actually I think are important, and they help us improve our work. And so I just want to acknowledge that so that I'm not running away from the failures. And then another thing, I can't close without talking about my work in St. Louis, because as I mentioned, I did some work as the lead chronic disease epidemiologist at St. Louis County Department of Public Health. One of my responsibilities was setting up this mental health surveillance, and that led as part of our first deliverables was to the production of this huge report with the St. Louis Regional Mental Health Board, St. Louis City Department of Public Health. For those of you who don't know, we have 2 departments of public health for some reason. That's a story for another day. And then I also led this minority youth violence prevention project that was delivered in North St. Louis County. And as you can see, this was awarded the model practice by Nature. For those of you who don't know, Nature is a big deal in local health. So this is National Association of County and City Health Officials. So we're very proud of that. And this is really as you can see, the reason I point this out, I've done a lot more than this at the county. The reason I picked these two is because there's a through line between my scholarship and what this is. So this has to do with violence prevention and mental health. And these are things that, I'm still planning to get engaged on to still do that work, to be able to continue that work focused on St. Louis. As we all know, you can't do this work by ourselves. We have partners that we partner with. We have funding agencies. I'm really, really grateful to the funding agencies that have funded this work and the partners that have helped us do this work. And today, again, January 20th, I can't close without saying the elephant in the room. Those of us who do global health work, don't know if we will be able to continue to do this work and how we will be able to continue to do this work. And public health is in a very challenging moment right now. Dean Galea writes about this in The Healthiest Goldfish, usually. So we are adapting and trying to figure out how to do our work, and we are figuring out where we can find new funding streams to be able to do this work. And really, so we have to do that. We have to adapt, and we have to be able to do that. I'll stop there. Thank you very much.
I'll start.
Yes.
Yeah.
Really wonderful presentation.
Thanks.
Something I've been wrestling with too, and you kind of hinted at it when you referenced Dr. Stark's paper that had just come out about, being in settlements versus out of settlements, and, some potential differences in how interventions might work or impact young people. I'm thinking about sort of like the compounded or continuing trauma that might be happening in real time as you're delivering these types of programs. And even for the people delivering in the interventions themselves. And, I'm just kind of thinking about how you're accounting for that or thinking that through in the testing. I mean, obviously you have the RCT model, but I imagine there's some, or RCT design, but some interesting kind of questions to ask there too, or important ones, I should say.
And I think that's a great question. Thank you so much. And I think Dr. Stark will agree with that. She's a mixed methods person. I think that's where she would probably go with that.
Right.
In terms of, we have to figure out what is working and what else is happening within that environment. And so asking qualitative questions to be able to figure out what is going on in the population is really important to document what else is going on. Some of the questions we ask our participants, like, because in some of these refugee settlements, there isn't anybody. We are the only people doing research. But in some of these also, there's a bunch of other people doing a lot of other things. So we always ask, are you in any other program? Because we want to know whether, it's if somebody else should get the credit.
Right, makes sense. Yeah, thank you.
Let's see.
So thank you. It was a great seminar. Really impressive.
Thank you.
Where you have so many different bodies of work and you tied them all together so well. So great job.
Thank you.
I had one I was curious about, and then one that's maybe a little deeper. I was curious, you said Uganda had some of the most progressive policy around. I'm curious why you think that is in the policy world. And then the second one, and we sort of talked about this a little bit this morning and it's woven in, but like, if you think about sort of the next few years, at least, things will go back. I mean, things will get better. We just don't know when they'll get better for public health and public health funding, especially globally. And I'm glad you acknowledged it is challenging now. But what are the things that you've most learned that might be transportable from your work in Africa back to the US, and whether it's St. Louis or Omaha or some other city where there's a lot of refugees being settled?
With that last portion. So thanks. I think, and as I mentioned earlier on, some of the work we do in Uganda, some of the problems that people have in that setting, I think are not different from some of the problems we have in North St. Louis, for example. I think I'll link there's this project that we were implementing in North St. Louis. I'd visit some of the schools, and there are schools that I remember one time the principal was very excited to show me where they had just installed new washing machines. And like, well, why do you need washing machines in the middle school? But because some of the kids don't go to school because they have dirty clothes, and so the school set this thing up so that they can come and do all of that. So there are a lot of similarities, and I think now more than ever, because of what's going on in the environment, it's really forming these partnerships with the community becomes really, really, really important, and being very intentional about that. So when we go to Uganda, for example, in northern Uganda, whether we're working with the Office of the Prime Minister or whether we are working with UNHCR, of course, UNHCR has their funding is dependent on us here, and some of the things, and the refugee communities, the leaders, the first question they ask you, are you just here? And then you're gone the next time. Building those relationships to say we are here to stay. We are here for the long term, and we are here to learn both from you. We are not coming here to, tell you, hey, this is what we know and you should do it. But what is it that has worked for you, and how can we help you make life better for you? I think I've heard people say you are an expert in your own lived experience. And so leveraging some of those things is really critical. And I think that's probably the best way to do it. And, implementation science, which, a very tiny bit about, and you know a lot about, is also another way to address some of these issues as well. In terms of the refugee policies, I can't put my finger around it in Uganda. So other than to say that Uganda has had refugees since the 1960s. And there are some South Sudanese refugees that have lived there since 1960s and have not gone back. Of course, in some of these border communities, actually, you have the same populations on either side of the border. So I could be on this side and my cousins live on the other side. And so maybe that makes it a lot easier for them to just say, you know what, we want you to integrate into the community and basically be productive. So UNHCR has this policy now where, self-reliance is another thing they've been pushing over the last few years. And so the countries that have been bought into that maybe are on the leading edge of saying, okay, if you can purchase a plot of land or lease a plot of land, you can cultivate there, and then you don't have to depend on anybody else. That takes the burden off of the government, first of all, and then off of these other people. And so that, from that point of view, I think that may be a way they're thinking about it, hopefully. And, and there was not just refugee policies, even HIV, they were on the leading edge of some of these practices as well. So, yeah.
Great talk.
Thank you.
And Julia and Ross asked my first two questions, so I'll go to my third question. I was really interested in the re-traumatizing question that's going on. So I'll go to the question you asked, and we talked about it before, like, why Nebraska? Why does Nebraska actually have such a high proportion of resettlement or refugees? And Google's our friend, so I was doing some Googling while we're going on, and what Google tells me is that there are historic welcoming factors. There's strong economic pull from the agriculture industries.
Yeah.
There is availability of affordable housing, whereas you wouldn't see that on the coast, and active resettlement agencies. So this is all leading to a question.
Yes.
And actually, I thought about it. The McBrides actually migrated to O'Neill, Nebraska back in the 1870s. And I say that it cites that this all started in the 1870s with the Homestead Act. So they have a historical pattern of helping refugees. So my question is, given that Nebraska apparently, and also St. Louis, around the Bosnian population, has this sort of welcoming attitude towards refugees in war trauma situations, how does that make you think about your project, where you might have it might be a little bit atypical of other places, and that these maybe somewhat more, I don't want to say favorable because it's such a horrible situation that they're coming from and being re-traumatized, but tell me how you're thinking through that.
So I think So it's Nebraska, and thanks for the education. So that's good to know. Now I have a sense of why people are settling there. And I've also even in, so I sit on there's something called the refugee task force now in Omaha, the Omaha refugee task force that meets monthly, that I sit on that board. And so I really, from that point of view, there seems to be this infrastructure to help support refugees in terms of what they do. And so that I think makes the job a lot easier. There are a lot of communities there now. There are churches that have been partnered with. There are these refugee. I love working with the Burmese community. They say they'll show up on this time. They show up at 10:45, 15 minutes before time. Great population to work with. Even here now we have, Congolese population that, refugees that, my colleague Chelsea, who used to work, and Anna used to work at the International Institute, who now work at ICAT. There've been all of these refugees that have come. And so that, thinking of just about my work, there's a lot of work to be done here, and we even in St. Louis here that can be done, and we hope to be able to do that to help support some of those refugees as well.